Welcome to our live webinar titled Understanding the MDS MPN Overlap. Thank you for joining us today. My name is Lee Clark, patient educator at MDSIF, and I will be moderating the presentation today. As we get started, we would recognize the generosity of Bristol Myers Squibb, Jazz Pharmaceuticals, Agios, Genentech, and Takeda, along with the generous support of our patients, families, and caregivers for supporting this webinar today. Due to the high level of teleconferences on the internet, it is possible you may lose your internet connection during the webinar. If you are unable to view the webinar online, you can call in and hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type in your question in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I respectfully ask that you do 2 things to help us manage the incoming question. Please submit your entire question all at the same time. Please do not share private health information in your question. Our speaker cannot answer any specific questions related to your health care. Today's specialist is Dr. Ruben Mesa. He is a director of UT Health San Antonio MD Anderson Cancer Center in Texas. Thank you, Dr. Mesa, for joining us today.
Well, thank you very much for the invitation. It's a pleasure to be here today and to speak on the overlap between 2 different blood diseases, the myelodysplastic syndrome and the myeloproliferative neoplasms. We're going to speak a bit about what these diseases are, how they affect people, the tremendous variability in how people are affected, but also speak on the treatment options. Additionally, we'll touch base a little bit regarding the COVID-19 pandemic and how specifically it impacts people who have these diseases, as well as we'll have plenty of time for question and answers. And that I'm sure for all of you, this is something that is, of course, very much top of mind. So first, these are awful long medical terms. Let's break them down a little bit. First, myeloproliferative neoplasm. What does that mean? That is a medical term for a bone marrow making too many cells. Myelo means bone, proliferative means making too many, and neoplasm, a reflection that the bone marrow doing this, these cells are all interrelated and makes it a type of a chronic leukemia. Now, under myeloproliferative neoplasms, we typically have diseases such as polycythemia vera, which frequently has too many red blood cells, essential thrombocythemia, which has too many platelets, and the disease myelofibrosis, where patients can have an enlarged spleen, can have anemia, can have difficult symptoms. All of these patients share a risk of blood clots. They have a risk of the spleen being enlarged, a filter for the blood. They have a risk of low blood counts, and they have a risk of the disease potentially progressing towards acute leukemia. So there's a variety of diseases all related in that, let's say, family of blood disorders. A cousin, if you would, of these disorders are the myelodysplastic syndromes. These are diseases that are related to the MPNs in that they are diseases that affect the earliest cells in the bone marrow, those cells that we call stem cells, specifically the stem cells creating the early cells we need in the bone marrow and making the red blood cells, many of the white blood cells, and the platelets. These are the diseases that we call MDS. Primarily, these individuals face difficulties related to low blood counts. So individuals that have anemia and that can have symptoms from anemia. Anemia meaning too few red blood cells. We need red blood cells to carry oxygen from our lungs to the rest of our body. So when we lack enough red blood cells, we can have fatigue, we can have shortness of breath. It can be harmful to us in a variety of ways. We can have too few white blood cells, and that can give us increased risk of infection. We can have too few platelets, and that can give us risk of bleeding, and that platelets are normally involved with the clotting of the blood. Patients with MDS most commonly have anemia, but may have a drop in all three of those blood counts. And the severity of that disease is in part related to, I apologize for looking off to the side. I have the Blue Angels literally flying overhead as they are acknowledging all the work being done here in the Health Science Center. So pretty cool that they're doing that. And I suspect in many of your cities, you've seen these occur as well. But back to MDS. So again, it's the drop in the blood counts that give these individuals a variety of difficulties with the disease. And like MPNs, they have a shared risk. We could go back to that second slide if we could, please. Or slide number 6, there we go. And like MPNs, they have a risk of progressing to acute leukemia. Now, these diseases are not completely distinct silos. They are diseases that can have shared features. And indeed, if one way that I try to use an example for patients is that there are patients that overlap and can have features that extend all the way from being almost like an MPN to almost like MDS to any features in between. So if you look at this example here of this blue arrow, there's people that almost live anywhere along this entire spectrum of difficulties. One analogy I use for patients when they have one of these diseases is if you were to think about North Dakota and South Dakota, there's individuals that live at either the northern end of North Dakota or the southern end of South Dakota. But there's also the people that live in the middle, on the border. You could think that the family is like the state, and you could think exactly how one individual is affected is like their county, their city, and even their street address, as we look at more and more specific information regarding how individuals are affected, whether it be by their symptoms, their blood counts, their bone marrow features, and their enlargement of their spleen. Now, within this overlap of MPN and MDS, there are some specific groups of patients within there. You can hit the next click. These are an example of some of the kind of subdiagnoses that fall under that MPN MDS overlap group and include chronic myelomonocytic leukemia, atypical chronic myeloid leukemia, juvenile myelomonocytic leukemia, MDS MPN with ring sideroblast or thrombocytosis, MDS MPN unclassifiable. Now, these are very complicated and cumbersome terms, but they were developed by those responsible for giving us exact diagnoses, which are our pathologists. These are individuals who, again, have developed international criteria based on blood counts, bone marrow features, and even molecular features to stratify what exact sort of disease a patient has, what to potentially expect, how to compare it to others. Next slide, please. Now, my colleagues, Dr. Brady Stein, if you could go back one slide, please. My colleague, Dr. Brady Stein, who's at Northwestern University, and Dr. David Steensma, who's at the Dana-Farber Cancer Institute, we worked along with AAMDS, as well as the MPN Research Foundation, to help to develop some educational materials regarding these overlap syndromes. Because as you might imagine, because of the terminology, they not infrequently cause some amount of confusion for individuals with these diseases, as well as to help to clarify issues for treating physicians. Next slide, please. Now, before we discuss the overlap, let me give you an example of a myeloproliferative neoplasm and then MDS, and then talk a little bit about the overlap. First, in terms of features, and then in terms of how we assess how severe the disease is. So first, what about clinical features? Well, myeloproliferation is the hallmark. And again, that just is a fancy medical term for saying making too many cells. Now, the reason that these individuals are making too many cells is typically there are acquired mutations that develop in the DNA, not from the time of birth, but as an individual ages, that is driving the bone marrow to make more cells than we need. And in myelofibrosis, an advanced form of these diseases, patients can have difficult symptoms arising from the disease. They can have low blood counts, although sometimes they can have high blood counts. They can have organomegaly, which means the organs are enlarged, most specifically the spleen, which is the most commonly enlarged organ, but then also potentially the liver. The blood and bone marrow have some features that are clues for us that a patient has this disease. Another long medical term, leukoerythroblastosis. What this means is that there are cells from the bone marrow that we can now see out in the bloodstream, that the bone marrow with the scar tissue that develops has become somewhat leaky. We could see that there's an increase in the early cells from the bone marrow, those cells that we call blasts. And that is something we track both in MPNs, MDS, and the overlap syndromes, and that all three groups of patients have some variable risk of progression towards acute leukemia. There are changes in the cells themselves. There are individual cells that are the precursors to platelets called megakaryocytes, and they look different or abnormal for these individuals. And then there is fibrosis. Fibrosis is another long medical term which means scarring, the development of scarring. Now, there are both genetic changes that we can measure from blood tests, genetic changes in different proteins, JAK2, CALR, MPL. These are all on-off switches that individuals that we have normally in our cells that might be abnormal in these diseases, as well as changes that can occur in the chromosomes or in the genetics of the cells. Now, for many of you that this seems just like too much information, realize that again, there's just a whole range of ways that the disease can affect you. Blood counts, symptoms, spleen, and all of these more technical laboratory studies that we can evaluate to see where along that spectrum of disease patients may stand. Now, we also look at the issue of prognosis. Prognosis means how threatening do we think a disease might be? Because depending upon how life-threatening a disease might be, it might have implications for us as to how aggressive we wish to be with therapy. All of the diseases that we're discussing today are diseases that potentially can be curable for patients going through what we call a bone marrow transplant. So bone marrow transplant can cure any of these diseases. Why do we not do bone marrow transplant in all patients then? Well, bone marrow transplant is probably one of the most complicated medical therapies a patient can undergo. And it can be life-saving, but it is a very, very intensive, serious, expensive but also potentially life-threatening therapy. So we have learned over time that there's very specific times that we should be considering that therapy, and other times where the likelihood of success is less than we would like, and we would not pursue that. Now, as we assess prognosis in this disease as well as others, we realize that several things are important in predicting that. Blood counts, symptoms, age, genetic factors. And although the exact way that the prognostic score varies between the different groups of MPNs, MDS, or overlap, the features between them certainly are shared between these diseases. Next slide, please. Next slide, let's do the MDS slide next, and then we'll come back to this slide. Perfect. So let's discuss the other end of the spectrum before we talk about the overlap. Now, for patients with MDS, the clinical features, they're less likely to have symptoms. Low blood counts tend to be almost uniformly present, particularly anemia. It's rare that the spleen is enlarged. The bone marrow has some features that are different than MPNs. They have what we call dysplasia. Dysplasia is a medical term meaning that when one looks under the microscope at individual cells from a bone marrow biopsy, they appear to be abnormal, that they have grown in an unusual way. Sometimes you have seen perhaps a fruit that you bought in the grocery store that looked like it grew differently, or a plant that grew differently. That's a sign of growth that was abnormal. This is an abnormal cell, but on a micro scale, just at the individual cell level. Additionally, they have genetic changes that can be present. Some of them are shared between the genetic changes that can be seen with patients with MPNs. There similarly are many prognostic scores that again stratify the risk for patients, in particular based on how low the blood counts are, how much risk of infection, bleeding, anemia, as well as movement towards acute leukemia. Why don't we go to the prior slide that showed the overlap? Now these are the overlap. So again, as you might imagine, there is overlap in the features between them. So maybe there are constitutional symptoms and maybe not. And again, the more constitutional symptoms, night sweats, fevers, fatigue, weight loss, itching, spleen-related symptoms, the more like an MPN the patient, that the disease that individual is facing is more like. Likewise, the more they lack those features, if there is no enlarged spleen, if there aren't any significant symptoms, it becomes more like MDS. The bone marrow similarly can show features ranging on the spectrum, but does show some amount of dysplasia to show that it is not purely an MPN, but that there's some amount of overlap. Indeed, there are individuals in here with the disease with ring sideroblasts. These are, again, cells that we could see within the bone marrow that can be associated with the JAK2 mutation, but does help to define one of those overlap syndromes. In terms of molecular features, many of them overlap to a significant degree with features one sees in MPNs or MDS. But there is also frequently mutations in another gene that can be seen when a doctor orders a broader genetic panel called the SF3B1 mutations. And these two can be associated with overlap syndromes. Additionally, there are CSF3R mutations that sometimes are identified in patients with atypical CML. So again, there's patterns of these 3 to 5 letter italicized genes that we use to really sort out where a patient stands. Frequently, your doctor will obtain from either your blood or from the bone marrow a myeloid panel that has anywhere typically between 30 to 100 genes that include all of these potential genes to see if one or more of them is mutated. And that also helps us to sort out where on that spectrum of chronic myeloid neoplasm an individual falls. Or that entire broader family of MPN, MDS, and overlap, all of that falls under the umbrella of chronic, to separate it from acute leukemias, chronic leukemias that originate in the myeloid cells. Now, the prognostic variables, again, are very much have some of the features that you saw both in patients with MDS and patients with MPNs. Next slide, please. And then one more. So how do we, back up one slide, please. So how do we treat these diseases? Well, as you might imagine from that discussion, this is a very heterogeneous group of patients. So to say that there is one approach would be incorrect. Let me go through a little bit of the treatment options that we have for each of the other 2 diseases, because we typically, for the patients that are in between these 2, we mix and match the therapies that we use for MPNs and MDS to best match the clinical situation that a patient might face. So first, I'll say that all of the diseases seen on this slide have some risk of progressing toward acute leukemia. And the greater that risk, or the closer a patient is to having acute leukemia, the more likely we are to consider aggressive options such as stem cell transplantation or bone marrow transplant. And we use those terms somewhat interchangeably. Now, what is acute leukemia? Well, acute leukemia is an extension of one of these diseases, or where an individual is first diagnosed with acute leukemia, where the early cells in the bone marrow are largely growing uncontrollably, or what we call with the increase in the blasts. Now, why that matters is that the blood counts then tend to drop very sharply and are very low. Infection-fighting cells of the white blood cells, or the infection-fighting neutrophils, being extremely low or life-threatening. Severely low platelets, giving severe risk of bleeding, or very severe anemia. Indeed, in acute leukemia, sometimes the bone marrow is hardly making any cells at all. It's something that we seek to avoid. So as we have therapies, part of our goal is to try to delay or push off acute leukemia because of its strongly life-threatening nature. For most individuals with these diseases, we either decide, should we observe the disease, or if the disease is giving an active problem to the patient involved, we use a therapy. So what therapies do we have potentially that we can use? Well, for MPNs, we have a few categories of therapy. First, these individuals have a risk of blood clots and bleeding, so we will consider the use of aspirin if appropriate, and use it in many individuals, typically at a baby aspirin level of 81 milligrams a day. Next, in patients with ET and PV that have high counts, they have risk of blood clots or bleeding, we may use medicines to lower the number of cells. Hydroxyurea, which lowers white cells, red cells, and platelets, interferon or long-acting interferon called Pegasus that lowers white cells, red cells, and platelets. Anagrelide, sometimes which lowers platelets. And we may use JAK inhibition, in particular for myelofibrosis or for polycythemia vera that has been more stubborn. Both ruxolitinib and fedratinib are approved as frontline therapies for myelofibrosis, and fedratinib more recently as approved as second-line therapy. These therapies can help to improve the spleen, symptoms, and likely even prolong survival in these diseases. The more a patient with MPN, MDS overlap clinically has features that are similar to myelofibrosis, big spleen, more symptoms, scarring, the more likely they are, we believe, to respond to one of these therapies. Now, patients with myelodysplastic syndromes can have need for transfusions. And indeed, that can be the case even with MPNs. If the red blood cell count is too low, whether that's under 8 grams per deciliter or most certainly under 7, we will transfuse patients. Platelet transfusions are utilized, but are much more rare in comparison for platelet counts that we consider to be life-threatening. Red blood cell transfusions hopefully can last a longer period of time in the body. Platelet transfusions tend to last a relatively short amount of time. We can consider erythropoietin stimulating agents. These are ones to help to boost the production of red blood cells. Drugs such as erythropoietin, darbepoetin, Aranesp, all are different names you may hear of these injectable medications. There is lenalidomide or Revlimid that can be particularly helpful in subsets of patients with MDS, particularly if they have the deletion 5q or have significant anemia. They are the cornerstones of therapy with what we call hypomethylating therapy. These are azacitidine and decitabine. Similar drugs that are given as injections. They might help to improve low counts. They might help to delay progression towards acute leukemia. They have been shown to prolong survival in patients with MDS. There's the recently approved luspatercept that is helpful for anemia in certain MDS patients and is also in trials in patients with myelofibrosis. Indeed, it's possible luspatercept may have a benefit for anemia in anyone on this entire spectrum, from MPN to MDS. And finally, we will use AML therapies, acute leukemia therapies, for patients before they have acute leukemia if we feel that acute leukemia is inevitable and we're trying to delay the onset of that. Now, patients in the middle of MPN, MDS, it really will depend on how the individual is affected. Do they have a big spleen? If so, we may be considering JAK inhibition. Have they had blood clots? If so, then we're going to be very mindful of where those counts are and whether we should lower them. Do they need transfusions? We'll certainly use those along the way. Should we be considering an aspirin? Do they have the deletion 5q? If so, they may benefit from lenalidomide. Do they have movement towards acute leukemia? And we consider either hypomethylating therapy or acute leukemia type therapy. We may consider those. Patients with chronic myelomonocytic leukemia are an overlap syndrome, but they have been studied specifically with azacitidine and decitabine and have some benefits, as well as JAK inhibitors have had benefit in those patients. Indeed, even in CMML, there are patients that are proliferative, have big spleen, lots of symptoms, and behave much more like myelofibrosis. There's others that are very hypoproliferative and have very low blood counts and behave much more like patients with MDS. Next slide, please. So that was a bit of a diagnosis in how we consider therapy. And again, therapy for patients with overlap is a highly individualized process, discussion between patients, physician, and the patient. But obviously, this webinar is quite a bit more complicated than normal, given the tremendous impact that we've had regarding the COVID-19 pandemic that has complicated life for all of us, not only in the United States, but around the world. And it has increased it further for those individuals that have difficult diseases, underlying medical problems, and it has been shown that individuals that have blood diseases, particular blood cancers like MPNs, like MDS, may have higher risks. So I wanted to take a few moments to share with you just some of the highlights of some of the discussion that's been going on that is relevant for this group, and then leave some time for questions, both regarding MPN, MDS, therapies for these patients, but also issues related to COVID as it relates to this piece. So first, the risk of COVID-19. First, COVID-19 is actually the name of the syndrome. The virus that is infecting people is the coronavirus. Corona is just a Latin word meaning crown, and that's just a bit of a description that the virus itself looks a bit like a crown under intense microscopes. Now, why this has been such a problem are a couple key things. First, it has been a very contagious virus, more contagious than most. Second, is that a percentage of the people that become infected, fortunately the minority, but still way too many, develop a very severe pneumonia from the infection. A pneumonia means infection in the lungs, and fluid builds up in the lungs, but the lungs become very inflamed. And the reason that is a problem is, of course, our lungs are where oxygen is exchanged from the air into our bloodstream. So when the lungs are inflamed, it interferes with oxygen getting into the bloodstream. So people need mechanical ventilators or other things to intervene to try to get enough oxygen into the blood to sustain life. That's where there's been all the discussion of intensive care units, ventilators, things of this nature. Now, patients with chronic blood conditions, are they at greater risk? Again, like the spectrum that I showed you, it probably exists on a spectrum. So other things independent of the blood are important. Is it a younger individual or an older individual? Have they been active and fit, or have they been debilitated and severely affected by their disease or other diseases? Do they have heart disease? Do they have lung disease? Are they of advanced age and have debilitation from that? So all of those are factors. In terms of the blood, how debilitated are they? Are they needing transfusions? Is their white blood cell count low or severely low to increase the risk of acquiring infection? We've been in close contact with our colleagues in Wuhan, China, in Asia, in Europe, particularly in Northern Italy, France, the UK, and of course here in the US, both in very highly affected areas like New York and others. And we do have concerns regarding higher risk for patients with blood diseases, but it is again quite individualized with other aspects of your health, your medications, all being factors in terms of what that risk looks like. We know during this time that it's important to stay in close contact with your physicians and your healthcare team. And frequently that has been occurring during this time through electronic visits, as well as other complementary ways to understand your risk and to understand whether there should be any change in the therapy that you're on. In general, we've been trying to leave people on their current approach in terms of therapy, because those therapies are important. And we fear that stopping any therapy that patients are on might actually have the underlying condition worsen and might ironically put them at greater risk. Additionally, we know that there is perhaps an increased risk of blood clots, severe blood clots such as stroke, occurring in individuals that have been infected with the COVID virus. As you might imagine, patients with MPNs that I had already mentioned have a risk of blood clots. We are concerned that they are at greater risk. We do not know that for certain. The information is continuing to evolve in a very rapid way for these patients, but that is at least a concern, and we are trying to be mindful of being aggressive in controlling the counts where appropriate for these individuals. Additionally, patients that have been affected by COVID, there are some of them that are put on protective anticoagulants at this time to try to prevent complications from occurring. Now, what about testing? The current time, the availability of testing is rapidly increasing across the United States. And let me say that there's testing really at two levels. First, there's the testing, do you have the virus at the current time or not? And now there have been multiple FDA-approved tests that individuals can have, and we'll get around to in a moment whether that is necessary. And then second, the testing that still is really being developed in terms of immunity, meaning have you already been infected and have antibodies in the blood? So first, testing to see whether you have the virus. At the current time, the testing has primarily been done in individuals that are symptomatic and we have concerns that they are infected. There has been relatively limited testing of individuals who are asymptomatic, don't have any symptoms of the COVID infection. Increasingly, we are testing people that are asymptomatic if we think it's important to catch the infection early. So at our cancer center, we have evolved now with broader availability of testing. We do test people who are receiving chemotherapy or starting radiation therapy or going to have a medical procedure or going to have a surgery or going to be admitted to the hospital. So we're not testing everyone. We're testing those individuals that we think are going to have something medically done that it would be good for us to know if they had the infection, because it may suggest to us that we delay doing that medical intervention until the infection has resolved. Now, regarding the testing of antibodies, at the current time, there's a few key things that we don't quite yet know. If we have antibodies, does that protect us against having the infection? And if so, for how long? So at the current time, one, they're trying to develop tests to be certain that if you test positive for having antibodies, that it's specific for the COVID-19 infection. The reason for that is that there are other coronaviruses, such as a cold virus, that we might encounter. And if we had a false positive, meaning we said that you were immune and you were not, and people viewed that as a way to separate if they're protected, it would not serve anyone. So the testing in terms of antibodies is a work in progress. Next, what about treatment? So at the current time, it has been a difficult virus for us to treat. There's a newly approved therapy called remdesivir, which is an antiviral therapy that actually was used against Ebola. And this is an IV drug, powerful drug, that has been used and is now being used in people who are in the hospital already very sick with a COVID infection. This would not be a therapy that someone who was at home that had the virus, who was not overly ill, would necessarily receive. There's multiple antiviral therapies that are being tested and ongoing. There's other therapies you've heard about on the news, some of which the results have been mixed, or other therapies like hydroxychloroquine, that the results have not been favorable thus far. But All of these are clinical trials which are ongoing that are being studied in a tremendously rapid fashion. Additionally, there are therapies that are being investigated to try to stop the inflammatory pneumonia or to improve it. So the medicine that I had mentioned, ruxolitinib, and potentially the other JAK inhibitors, can help to block inflammation. And there have been some benefits of use of ruxolitinib in people who were severely sick with COVID on ventilators. And now there is a clinical trial looking at it in those patients. Independent of the issues of MPNs or MDS, just using it for its own parts. Now, what about getting healthcare during this time? I think the key is, the current period that we're in, which is slowly evolving away from the peak, means that there is not going to be a period without a risk in our society for the immediate future until we have a vaccine, which hopefully will be sooner rather than later. No one truly knows when, but I know every effort is being done to find an effective vaccine and have it be broadly available. But during the current time, it's important for you to continue on with your healthcare. Individuals that have these diseases, these are difficult diseases, and they are ones that we really cannot ignore for an extended period of time. Maybe individuals have delayed or canceled appointments in March or April in the hopes that they could then have those appointments in May or at latest June. We realize that there is no endpoint in the immediate future, so important that you be connecting closely with your healthcare providers, whether that be a face-to-face visit or through an e-visit. During this time, if you have severe healthcare needs, chest pain, shortness of breath, blood in the stool, anything acute, get urgent medical care. You can now, perhaps at the beginning of this crisis, there was a lack of gowns and there was real risks in going in for medical care. Now, I'd say across the US, healthcare systems have been much better stocked, and you clearly can go into an emergency room or a doctor's office in a safe way. If it is not urgent, you can certainly connect with your physician first in terms of how best to get assessed. Most of them, if what you are concerned is whether or not you have the COVID infection, if it is not severe, meaning you're not having acute shortness of breath, chest pain, most of them will have you tested in a way through a drive-through test or another, so that you're not necessarily coming into the ER to be assessed for the COVID infection. We're approaching it that way to try to decrease the risk of people sharing amongst them. Now, what about impacts on treatment? Well, when March and the beginning of April rolled around and we had thought that the period of greatest risk was going to be very short, a lot of treatments were put on hold. I think we have evolved quickly away from that, fearing that holding treatments would be harmful to patients, and knowing that there's not an immediate endpoint that dramatically changes the risk in society now in May or the beginning of June. So I think the question now is, how do we proceed forward in the best and the safest way that we can? And part of that is trying to keep our medical environments safe. So for example, at our cancer center, probably similar processes to many other cancer centers, as I'm in discussions with others, we screen people at the door for fever with symptoms. People get a sticker, just like this sticker I got here today. I get screened like everyone else with a temperature, with questions. I wear a mask. I'm in my office alone, which is why I'm not wearing a mask, but otherwise would be wearing a mask, having all of the surfaces closely cleaned, keeping individuals socially distant if they are in waiting rooms. In other areas, such as those awaiting treatment, in infusion or for radiation therapy, we actually have them wait in their cars, and then we text them so that they can come directly in for treatment. The final, as it relates to these diseases, is the issue of stem cell transplant or allogeneic stem cell transplant, cells from someone else. These individuals, their immune system is tremendously compromised during the process of undergoing a stem cell transplant. So at first, there had been a bit of a hold on proceeding with these transplants during the peak of this crisis, But now as we're evolving out, that is an active discussion between yourself and your transplant physician, but likely to be moving forward, trying to have that be as safe as one possibly can be. Those individuals that are stem cell transplant survivors should already be in close contact with their healthcare team regarding how to keep safe during this time. Indeed, I'll conclude by saying, this is an infection that none of us want to have. And although there's certain groups of people that we fear have a higher risk, we realize that is anyone can become severely sick from this or potentially spread it to others. So patients with chronic blood diseases, such as yourselves who are on this call, best to be prudent during this time, follow your local advice quite rigorously, use masks when in public for the time being, keep socially distant, and remember the primary way that people acquire this infection is they touch something and then they touch their face, meaning the eyes, the nose, the mouth, as ways that the virus can get into your body. It does not get into the body through hands. So people ask, well, should I wear gloves? It's not been found that gloves are particularly helpful because you can have the virus on your gloves just the same as your hands. And sometimes people incorrectly feel that they're more protected with gloves and are more likely to be touching their face. So really frequent hand washing, realizing that your hands are the primary way that that virus is likely going to get into your body through your eyes, nose, or mouth. It's an awkward thing to get used to, but it's crucial doing that out in public. So a bit of a high-level overview on MPN and MDS and a deeper dive in issues as they relate to COVID. Now we have a few moments left. I'll be happy to take some questions.
Right. Thank you, Dr. Mesa. We do have a few questions. The first is, are transfusion thresholds being altered at this time for patients with MDS and the MPN overlap?
That's a very good question. In short, no. Over time, the American Association of Blood Banks, independent of this issue with COVID, has had us try to be more stringent on when patients get transfused red blood cells, down to a level of 7 grams per deciliter, unless an individual is having shortness of breath or significant symptoms. So we can transfuse a patient above 7 if they're feeling very short of breath or having other symptoms. So since we've already been a bit more stringent in terms of the cutoffs, I probably would not be more stringent than that, because the fear would be, although in the ideal world, would it be safer if you didn't go in? Probably slightly, but the risk in terms of remaining that anemic probably far outweigh the risks of going in to receive the transfusion. Because when you don't have enough red blood cells, your heart, your brain, and other key organs in the body are not receiving enough oxygen, and that puts a real stressor on your body, as well as clearly impacting how you feel and your quality of life.
Thank you. Has there been a change to the protocols for patients during this time in regards to fever and when they should contact their physician?
It's a good question. In short, no. Indeed, probably being more proactive in terms of contacting your physician during this time. And the reaction may be different than in the past. In the past, we really only had one option: for you to come in to be evaluated. Now we're able to potentially visit with you by an electronic visit to help to sort that out. We realize that fevers and symptoms, both from disease and or results from therapy, did not go away because we had the COVID infection. In fact, it just added another reason that you might have fever. But of course, the normal reasons for fever didn't go away in terms of other infections. bacterial infection, strep, or other things. So probably even more important to contact them. And again, most have probably established a way to evaluate, visit with you either electronically or in person, and help to sort out, is it from the COVID infection or is it from something else? Do we need a COVID test, or do you really need other tests or perhaps antibiotics?
Thank you. Is there any knowledge of an MDS patient being asymptomatic and then testing negative?
So in terms of false negatives, we don't have a sense that patients with MDS or overlap syndromes are more likely to have a false negative test for the infection. So the results of testing for the infection should still be accurate because they're not dependent on the white blood cells. So even if a patient had very low white blood cells, the test, which is looking for the presence or absence of the virus, will likely be accurate for those individuals.
Thank you. Are there any recommendations for patients during this time to use any type of complementary alternative therapy to help with boosting their immune system?
It's a good question. We know that a few key things are important. So one, probably taking a multivitamin, if your doctor is comfortable with that, is probably helpful during this time. It's interesting, we found, at least at a societal level, that although there is sometimes even significant obesity in our society, people's nutrition in terms of all the different vitamins and elements that their body needs to maintain a good immune system sometimes is lacking. Even if they have plenty of calories, they may not have necessarily all of the nutrients in their diet that really give them an optimal immune response. So I think, from everything that I've heard and read and interacted with our infection control experts, you probably don't need to do the extremes of any specific vitamin, but a general multivitamin probably is helpful. Other important things such as sleep, and trying to be active, maintain being physically active, trying to get fresh air in a socially distant way, but again, trying to keep your sanity, be well rested, eat well and balanced, a multivitamin, all of these things incredibly helpful. I do think there's a whole range of things from the complementary arena that are very helpful to us trying to keep the kind of the inner peace necessary to kind of go through such a period, whether that be through meditation, through yoga, many of which are things that can be obtained online. I know one example that we've done some clinical trials with called Calm, which is an app, really can be quite helpful for folks, both with insomnia as well as dealing with stress.
Thank you. This question comes from a patient who has been diagnosed NPL, IDH2, SRSF2, diagnosed with MPN and has a very high monocytes. Are there any new treatments using monoclonal antibodies?
So there are specific now approved inhibitors of IDH1 and IDH2 mutations. Now, clearly a decision between a physician and a patient whether that particular type of therapy would be helpful for that individual. In terms of monoclonal antibody type therapy, not specific for any of those one mutations yet. Again, with monoclonal antibodies, we can target a specific abnormality. The problem is trying to target only the abnormal and not the normal. And all of these mutations are mutations in genes that we need and are present in many of our cells and have many important functions. So people say, well, why don't we just use an antibody to destroy all the cells that have MPL or IDH or SRSF3. And unfortunately, that is part of the challenge. How do we only get to the cells that are have the abnormality and impact them specifically? But increasingly, we will have more specific targets. So IDH1 and IDH2 inhibitors are one of those, but they are used in the most aggressive circumstances and approved for acute leukemia.
Thank you. For an MDS 5Q patient, what things do you look for to check to see if the disease is progressing towards leukemia?
So in all patients, both with this individual and others with MDS, MPN, or somewhere in between, the main barometer is the blast percentage, in particular in the bone marrow, but also sometimes in the bloodstream. Normally in the bloodstream, we don't have any blasts. And in the bone marrow, we have less than 5%. Having some blasts is necessary and normal. In my bone marrow, knock on wood, my blast percentage should be 5% or less. That would be normal. Acute leukemia, the threshold is a blast percentage greater than 20%. Now, why that matters is that as the bone marrow becomes more consumed with making blasts, it is impaired from making the other cells that we need. So typically, as the blasts go up, the patient becomes much more anemic, severe drops in the white blood cell count, and severe drops in the platelet count. So we clearly track the counts, but the blasts are really the gold standard for assessing, has someone, are they moving toward acute leukemia? So a blast percentage between 5 to 20%, or do they have acute leukemia and it's over 20% in the bone marrow?
Thank you. If the SF3B1 gene is present, does that make the diagnosis of MDS and myelofibrosis conclusive?
No. So it certainly can be in there, but a mutation alone does not mean that someone has one of these particular diagnoses, but it makes it more possible. So there are times that we have individuals that have a clone like this in the blood, but do not have an illness. So there's circumstances of what we call CHIP, or clonal hematopoiesis of indeterminate potential, where blood counts are normal, somebody is aging, and there is a clone that has one of these mutations or more in the bone marrow. These individuals may end up progressing to have a blood disease, but there's a lot more we are learning, because part of the process of developing these mutations is associated with the process of aging. Now, in many, that process can evolve and cross the line from being just present to manifesting with changes in the blood counts and illness. So that might be a part of the diagnosis, but a molecular mutation alone doesn't necessarily mean that you have one of these conditions.
Thank you. When blasts show in your blood work, is it referring to your blood or your bone marrow?
So they'll report it in either, but a normal peripheral blood does not have any blasts. Now, if it's present, it would be unlikely to be present in ET or PV. They can be present in myelofibrosis, and it can be present in MDS if the disease is starting to progress. But the normal complete blood count will not report blasts, because normally that number is by default 0. The bone marrow, they'll always report on the blast percentage, because it should at least be 1 to 5%, even in the normal state, and potentially higher than that if there's evidence of progression.
Thank you. Is 1 to 3% blast normal for MDS?
That would be normal for anyone in the bone marrow. In the peripheral blood, that would be a sign of at least baby steps towards the disease progressing. But in the bone marrow, that would be a normal blast percentage. Not even just normal for MDS, that's just the normal value. Patients can have MDS and not have an increase in blasts.
Thank you. What percentage should you be concerned about, meaning that your blasts are, that you're evolving, your disease is evolving?
I think clearly above 5% in the bone marrow. So, up to 5% is the normal cutoff. So if it's at 5, it makes it a little bit more difficult to sort out. If individuals, it's clearly above 5, 7, 8, 9, 10, or especially above 10% in the bone marrow, then we have a concern that the disease is moving towards acute leukemia and likely will end up evolving into acute leukemia. In the peripheral blood, values above 1 to 2%, again, are also concerning for a clear increased risk of progression toward acute leukemia, with values above 10% making the future evolution to acute leukemia probably all but certain.
Thank you. And one last question. Is there a new medication to reduce bone fibrosis and myelofibrosis?
Well, certainly there have been many therapies that are trying to impact that, either directly or indirectly, ranging from the BET inhibitor from Constellation, patients on JAK inhibitors with fedratinib, ruxolitinib, momelotinib, pacritinib, all have had individuals that have had improvements in fibrosis. There's anti-fibrosing drugs from a company called Prometeor. There is an agent working against megakaryocytes from a company called Imago that may work against fibrosis. So many that are looking to improve the disease, and then as a second step, yes, the scarring is better. None that are approved yet, none that only work against fibrosis, but that clearly is a very important target.
Sorry, we have one more question. Can a combination of Vidaza, Jakafi, and IDH2 drug be combined? If not, why?
Well, certainly all of those are drugs that can be used, and a physician would be able to give all three together. There are clinical trials looking at any combination of these. The downside is that they may drop the blood counts excessively. So therapies like this, one typically would only be given together in the setting of disease with significant risk, and there is risk that the blood counts could drop to a significant degree, and have potentially life-threatening complications would be kind of the downside. But this is an approach that certainly, may be beneficial, but certainly needs to be done with caution. There are clinical trials trying to understand that more. There are physicians who may well use all three in an individual in front of them and can do so, but just needs to be done with caution.
Thank you so much, Dr. Mesa, for taking the time today and sharing your expertise with all of us. If we were not able to answer your question today, you can send it to us at any time 3 ways. You can send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, we thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are here to help you and your family, as we have done for the past 36 years. Thank you, and this concludes today's program.
Bye-bye.
Bye, Dr. Mesa. Thank you.